All right, thank you, Dr. Vidal. So here's my disclaimer and my disclosures. So acknowledgement, I just want to thank SIR and Terumo for hosting this session, and Dr. Vidal, he's been a great mentor to me, and I'm going to go through that here in a bit, as well as my colleague back at Mayo, who's further helping develop our embolization practice. So I want to take a step back, and I want to talk about how we developed our multidisciplinary practice for hemorrhoid embolization at Rochester and our patient selection, because I think sometimes, especially when you're new, I'm 4 years into my faculty role, it's helpful to see how the road others have gone on. And then I'll show kind of a spectrum of cases that we've encountered early in our practice. So it really was serendipitous that I even stumbled upon this topic. So I'm one of the section editors for radiographics, and I actually was the reviewer for Dr. Vidal's radiographics paper. And that was the first time I learned about embolization for chronic rectal bleeding or for hemorrhoids. And this was not being considered at all at our institution. And so I actually had the chance to attend CIRSE that year. And I emailed Dr. Vidal. I didn't know him. Emailed him, and he very graciously sat down with me at CIRSE, talked to me about hemorrhoid, and went over cases with me. And I say that just to say, one, it's really helpful to find mentors, and I'm very grateful. So went back to my institution, and that's where I went back and learned about our local practice. Who sees the patients with anorectal diseases? At our institution, there's a clinic that's primarily staffed by colorectal surgery advanced practice providers, NPs and PAs. And they're really the first line that see the patients, do the anoscopy, and think through the initial evaluation. They talk through patients with conservative and dietary measures. They are the ones who do the in-office banding procedures. And if they think a patient might be a candidate for hemorrhoidectomy, then they get the surgeons involved. But they don't offer any of the other minimally invasive options that have been discussed. So then I presented the data that at that point there was meta-analyses on the safety and efficacy of hemorrhoid artery embolization to the colorectal surgery group. And we started our own outpatient clinic that was staffed by myself as well as some of our advanced practice providers in IR. And we did our first case in May of 2023. And then, fast forward a year later, we've launched now a prospective trial on outcomes and quality of life after hemorrhoid embolization. This is a study that I'm the PI, and a co-PI is from our colorectal surgery group. And I want to emphasize again the importance of forming that collaboration. And we've done a number of other outreach things. There are a lot of other stakeholders at our institution that see these patients, not just colorectal, but also the primary care, family medicine, general internal medicine physicians. And we've also done talks at internal medicine and family medicine grand rounds. So some of the key lessons that I learned early on were find a mentor. Really key to understand the local practice patterns for hemorrhoid treatment. It'll be very different in different areas. Sometimes the gastroenterologists are involved. In some places, hemorrhoidectomy is the bread and butter of the colorectal surgeons, and they're not going to want to give up these patients. At my institution, the colorectal surgeons are happy to avoid doing hemorrhoidectomies. And form these collaborations, make it about the team and how you can help the patients. And I think most importantly, be a clinical interventional radiologist, not just a proceduralist. And by that, I mean, I see these patients in clinic. I communicate very closely with the colorectal teams, even sometimes the primary care providers, as I'll show in one of our cases, and be there in their follow-up. It's a collaborative thing, but you don't want the other stakeholders to think you're just going to do a procedure, send the patient back. This is my workup. Most of these patients have seen colorectal surgery. If they haven't and they come directly to me, I do have them see colorectal surgery. I also see them in clinic. They need to have had anoscopy, and they need to be updated on their colonoscopy. We do some basic labs, and we don't routinely do imaging of the pelvis in these patients. If they've never had any imaging of the pelvis, we do get a pelvic CTA. The vast majority of these patients have had some cross-sectional imaging of their abdomen and pelvis previously. And we also obtained the French bleeding score, the hemorrhoid bleeding score, and their quality of life questionnaires at baseline. We see these patients at 1, 3, 6, and 12-month follow-ups. At 6 months, that's when we really want to see these patients back in person. We are a small community of only 120,000 people. A lot of our patients are coming from far away. So for us, we do a lot of phone and video visits when we can, but we do want these patients back at 6 months, not only to see me, but also see colorectal surgery and get repeat anoscopy. If they develop recurrent bleeding along the way, we can consider a repeat angiogram, but it really is an ongoing multidisciplinary collaboration between us and their colorectal surgery team. Now, in terms of patient selection, I follow what I've learned from Dr. Vidal. This is really our updated colorectal surgery guidelines, and hemorrhoid embolization is not in there yet. And we, again, as Dr. Vidal mentioned, our sort of sweet spot are patients who have grade 2 and 3 hemorrhoids based on the Goller classification. Grade 4, we'll talk about where that fits in. And all of the patients in our group undergo that French bleeding score, the hemorrhoid bleeding score. Dr. Vidal already mentioned this, but what we tell our patients is that they have an 80% chance of a significant reduction in the frequency and severity of their bleeding by that French bleeding score, and an improvement in their quality of life scores. And I think importantly, we've not seen up to this point in these meta-analyses any major complications. So for our practice, our patient selection is primarily inclusion criteria, or takeaways from the literature are primarily grade 2 and 3 disease with bleeding predominant. That really has to be the key symptom. If they just have pain, that's not a patient that we are looking to treat. We'll go through in a second our algorithm, but really we're trying to treat the superior rectal artery plus or minus the middle rectal, depending on what we see angiographically. And as Dr. Vidal mentioned, lowest rebleeding rates are with large particles plus coils. And response evaluation, we use those bleeding scores and quality of life. So in terms of our inclusion criteria, grade 2 and 3, and then I'll say plus or minus grade 4. We will make exceptions for that in certain cases, especially if they are not going to be ever a surgical candidate, or if the surgeons really want us to try everything before they undergo surgery. They typically have had to have at least tried some of the dietary and hygiene measures. They don't necessarily have had to undergone banding. Some patients, and patients will tell you if they've undergone banding. Some have horrible pain. It can last for days. It keeps them out of work. And I think that's not the prevailing, at least what was my understanding of what banding was supposed to be like. And bleeding really has to be the predominant symptom. You'll hear me say time and again, bleeding predominant internal hemorrhoids, that's really, I say that not just because that's the patients we want, but when I put that in my dictations and so forth, we don't get trouble from insurance companies getting this approved because we're trying to prevent bleeding. That's really our main goal. Exclusion criteria, and I think these are equally important. As Dr. Vidal mentioned, grade 1 disease are the people with really minor hemorrhoids. That's not a group that we treat. And then really grade 4 disease is on a case-by-case basis. People have acute hemorrhoidal complications or chronic anal or perianal fissures. This can be problematic. It can confound the pain that these patients have, and we require these patients to have had a recent anoscopy so we can determine if they have any chronic anal or perianal fissures, and these need to be resolved before we will treat them. If they've ever had a history of, and I don't mean all colorectal surgery, but really rectal surgery or pelvic radiation, especially if they've had some GYN surgery or something like prostate cancer radiation, those are patients that we're more reluctant to do just because those tissues are going to be more susceptible to ischemia. People with chronic inflammatory bowel disease is a group that we want to avoid, particularly ulcerative colitis. Now, portal hypertension, mesenteric venous congestion has an asterisk by it. We will treat those patients. It's not an absolute exclusion criteria, but I will say anecdotally, these patients do not do as well in our experience with this procedure, but again, we will consider them on a case-by-case basis. And then any patient who has really severe atherosclerotic disease, their IMA or internal iliac arteries, whether they're stenosed or occluded, or if they just simply can't get contrast. So now I want to go through some cases in our sort of general approach. So our general approach is we have done most of our cases transfemorally. We've done a handful of cases transradially. And I think it's key to do good selective angiography. Dr. Vidal showed several cases already where it's really key to get selective so you can identify any of these anastomotic branches. So identify the hypertrophied branches supplying the corpus cavernosum recti, and then treat the superior plus or minus the middle rectal in that first stage. We use large particles. We're typically using 800 micron particles with dense coil packing after that. And as Dr. Vidal mentioned, we're using very small volumes. I mean, I take the 800 microns and I dilute it up to 20 cc's, and in a vessel we might be using 0.3 of a cc, 0.4 of a cc, so it's a really small volume. And our goal, angiographically, is to eliminate the arterial flow to the corpus cavernosum recti below the superior aspect of the pubic bone. It's just a nice anatomic landmark to think about where we want this to end. And as I mentioned, we do longitudinal follow-up. And we ideally want to wait 3 months to see if the patients are going to have a reduction in the frequency and severity of their bleeding before considering a stage 2. So this is the algorithm that Dr. Vidal and his team more recently published, and this is really the approach that we take with doing a good superior rectal artery angiogram. If the superior rectal artery is hypertrophied, we treat that in the first stage. If we do see reflux into the middle rectal artery, we'll either interrogate it, if we can, going from the superior rectal arteries or selectively from the middle rectal arteries themselves. And if the superior rectal artery does not supply the hemorrhoids, we will then interrogate for middle rectal contribution. Now, I'm just going to walk through kind of a couple cases really spanning a spectrum of things we've seen, throughout our cases, and I'll highlight their clinical histories and outcomes. First case was a 46-year-old male. He had grade 3 bleeding, predominant internal hemorrhoids. He also had external hemorrhoids. One thing to really mention to these patients is you're not treating their external hemorrhoids. They will ask you about that, and it's really key to counsel them that this is not going to be treating that. This is treating the bleeding from their internal hemorrhoids. He had the bleeding score of 6 to 7 out of 9. His quality of life was really poor. He said his life was on hold at that point due to bleeding, and he had multiple ER visits for bleeding. So here's the non-selective superior rectal artery angiogram with hypertrophy of the bilateral superior rectal arteries. You do selective injections on the left side first, and you can actually see here on, we get reflux with a really selective injection into both middle and inferior rectal arteries from this one. And then we do subselective angiography on the right side, and we embolize that. And so we did subselective embolization of 5 superior rectal artery branches using a combination of particles and coils, and there was no residual flow to that corpus cavernosum recti. And so I'll just briefly show sort of generically tools and things we use, but this was femoral access. We used a 5 French sauce catheter for the IMA, a 2.4 French microcatheter, and then we'll sometimes use an 018 microwire as we get down and an 014 wire as we get closer, 800 micron particles, and 2 millimeter helical and packing coils, and then a closure device. So in terms of follow-up, there were no peri-procedural complications. This one's relatively short-term follow-up, but has had resolution of his bleeding. This was somebody who was having bleeding with every bowel movement and is now having well-formed stools with these bowel movements or spontaneously. And so for each one of these, I'll try to highlight a teaching point or two. And I think, as Dr. Vidal already mentioned, it's really important to do subselective injections of these superior rectal artery branches. Not only confirm the hypertrophied branches, but also as you start to embolize these, the flow can start to change, and you can start to see middle and inferior rectal arteries that may start to provide more flow. Second case is the one that's going to highlight a middle rectal anastomosis. This was a 73-year-old female. She had grade 2 bleeding, predominant hemorrhoids, high French bleeding score. Quality of life score wasn't too bad, but the bleeding was really bothersome. And she had previously undergone an attempted banding procedure that was aborted due to severe pain. So here's the non-selective IMA angiogram. We can see there are hypertrophied branches of the corpus cavernosum recti, but there's also this anastomotic connection here to a right middle rectal artery. And so we do subselective injections on the left side, we do subselective and embolization, subselective injections on the right side, and we make sure we can get past this area of the middle rectal artery. Here's actually an anastomosis with the inferior rectal artery on that side, and we make sure we embolize with particles and coils so we can shut down those anastomoses. And so we did subselective injection of 3 branches, no residual flow there. This was a radial case. We used a 5 French MG1 catheter, a 4 French Cumpy catheter into the IMA, a 2-4 150 centimeter catheter, and in this one used a combination of 6 and 800 micron particles with a 2 millimeter helical coils. No peri-procedural complications, and they've had no recurrent rectal bleeding at follow-up. And so, again, important to do adequate selective injections of these superior rectal artery branches so we can identify those middle rectal artery anastomoses, and if we see that, we either go to it directly and treat it, or we can use, if we can, embolize the anastomoses with particles and then coil across them. This is a third case. This is the case that experienced recanalization. This is something that I was surprised by, but I think it's something to know that it can happen. This was a 69-year-old female. She had grade 3 bleeding, predominant internal hemorrhoids, French bleeding score of 7. She was iron infusion dependent. She'd undergone prior rubber band ligation procedures. One thing to note is at least in our practice, our colorectal team will only do they'll only band 2 columns in one session, and they'll really only do up to 2 sessions. So she had already had that, and she was not a surgical candidate. She also had Klippel-Trenaunay syndrome. She had extensive pelvic venous collaterals, not rectal varices, but the surgeons had absolutely no interest in operating on her because of her underlying venous disorder. Now, we don't routinely get CTAs in these patients. She had this as part of her Klippel-Trenaunay follow-up, but this is what you can see sometimes on these CTAs is the early arterial enhancement of that corpus cavernosum recti that fills in on the venous phase. In some ways, it's a little bit like a slow flow type of AVM. So in her, She had relatively small superior rectal arteries, but when we got more selective, you see the dense staining of the corpus cavernosum recti, and we did subselective embolization on both sides of the superior rectal artery with no residual flow. Now she had no complications. She had a significant reduction in the frequency and severity of her bleeding up for 6 months. She was very happy. In that fall, she developed COVID, had like a prolonged period where she had severe coughing and developed recurrence of bleeding. So we said, okay, let's bring you back for a repeat angiogram. And we did, and she had some recanalization or at least collateralization from superior rectal artery branches, so we did additional particle and coil embolization of those. But we then looked at her internal iliacs and had this right middle rectal artery that was giving some supply, and so we treated that as well. Really similar approach in both cases with 800 micron particles and coils. And now in follow-up, she's had no complications. She's 15 months out from her second stage, and she's had a marked reduction in the frequency and severity, and she's doing really well. Again, I think it's really important in these patients to counsel them, and I tell them 80% of you are going to have a significant reduction in your frequency and severity of bleeding. That doesn't mean it's going to go to zero, but we're trying to improve your quality of life. So, one thing I learned from this case was, really having that dense packing of coils is really, can be really important. And if they develop recurrent bleeding, repeat an angiogram, look for either recanalization or collateralization from the superior rectal arteries or middle rectal artery supply. This fourth case, I call this an AVM-like internal hemorrhoids. I've seen this twice now. This is a 30-year-old male, a 3-year history of, so really young guy, 3-year history of grade 3 bleeding predominant hemorrhoids. He had iron deficiency anemia, and he had undergone 3 prior banding procedures and exhaustive conservative measures back at his local hospital. Then came to our colorectal team, referred to us because he really wanted to avoid hemorrhoidectomy. He had a moderately elevated, bleeding score, but his quality of life was really impacted because he would get spontaneous bleeding. That was, he would say, I was at a, college basketball game, and all of a sudden I felt blood running down my leg. So it was really impacting his social life as a young man. So here's his angiogram, and so this superior selection of the superior rectal artery, there's really this dense staining of the corpus cavernosum recti, and you can actually see arteriovenous shunting through this. It wasn't as rapid as you see with AVMs, but nonetheless there was this very, what we would look almost like an early draining vein. And so we did subselective injections, that dense staining of the corpus cavernosum recti with really slow shunting into the venous system, and then same thing on the left side. So we did subselective embolization of 5 of his branches with large particles and coils with no residual flow. This was a femoral access case, very similar, used 800 micron particles, 2 millimeter helical coils and packing coils. And so he's had no peri-procedural complications, and he's had a marked reduction in the frequency and severity of his bleeding. If you ask him, he'll say, I think I'm about 50 to 60% improved. His French bleeding score went from 6 to 3, his quality of life from 3 to 1. And really the key thing, and this is what Dr. Vidal mentioned, is we can measure these things, but at the end of the day, it's, are you happy with where you're at? And for him, he said, this is no longer bothersome for me in my life. And so that was really a huge win for him. And Dr. Stewart got into this a little bit on the pathophysiology, but really, there are direct arteriovenous communications within these terminal branches of the rectal and hemorrhoidal artery plexuses. And I think in some of these patients, these things can almost look like slow flow AVMs. Fifth case, this is one where a lot of arterial disease. 72-year-old female, longtime smoker, 13-year history of grade 2 and 3 bleeding predominant internal hemorrhoids, also had external hemorrhoids and fecal incontinence. Had iron deficiency anemia, had undergone 2 prior banding procedures and exhaustive conservative measures. Really high bleeding score and high quality of life score. So came in and did my selective superior rectal artery angiogram. And there was a high-grade stenosis in only this branch that was going to the cross-filling to the left superior rectal artery. And it was, about probably 90+% stenosis. So not something I could easily cross. So this patient actually had a CTA, and I scrubbed out, took my gloves off. My colleague and I looked at the CT, and we said, gosh, there's something coming from the obturator. And so from the right pelvis, and there's this obturator branch. And so then we subselected the obturator, and sure enough, here's this collateral branch filling the superior rectal arteries from the obturator. So we actually had to cross this collateral, got up and over to the left superior rectal artery. Here we were. At this point, because I was crossing this narrowed vessel, I basically had no flow once I got down here. So this is one where we just treated with coils at that point. And then I pulled back into, so yeah, this is a very gentle injection. I had no blood return just to prove where we were. I would not recommend injecting hard because you will rupture those vessels. So treated that side with coils, came back to the ipsilateral side, and this side had flow, so we treated with particles and coils. So a little bit of a different approach in this one. We got thrown for a loop. One thing I will say is to get across this, I had to change out for a, pardon me here. When I got to get across over here, I had to do a wire exchange over a 300 centimeter 014 microwire for a 2 French microcatheter because the 2.4 would not track. And then we embolized that obturator collateral. And she's had no complications. She said she thinks about a 50% reduction in her bleeding. Her French bleeding score went from 8 to 4, quality of life score from 3 to 2. Now, she did ask me in follow-up, is there anything more that we can do? She's got a lot of comorbidities, a lot of things going on. And so she's happy with the improvement, but she wanted to know if there was more. Actually, just this last Friday, I treated a left middle rectal artery in her. So in this one, small vessel disease, particularly the superior rectal arteries, it may not be evident on the pre-procedure CTA. We went back and looked at the CTA, and it's very hard to tell that this degree of vascular disease. And if you have a CT, look at it for a variant anatomy and have a smaller microcatheter on hand for certain cases. And then here's my last case. This is my most challenging case that I've dealt with. This is the nicest woman in the world. And she's 56. She had a history of a right colectomy with an ileocolic anastomosis. She hated when she had her ostomy. She never wanted to have an ostomy again. She also had a right lower quadrant functioning pancreas transplant and a left lower quadrant functioning renal transplant and multiple comorbidities. And she really had longstanding grade 3 and 4 bleeding predominant internal hemorrhoids, innumerable ER and hospitalizations for bleeding. Her hemoglobin never could get above 8. It would nadir around 5. So French bleeding score was high, quality of life was high, and because of the immunosuppression, the surgeons wanted to avoid hemorrhoidectomy if at all possible. And the key thing in her was she kept getting these blood transfusions, and it's not good for somebody with these transplants to continue to get these transfusions because it will increase their risk for rejection. So I reluctantly undertook the case, and we also had a very extensive conversation with her primary care doctor, who she had a wonderful relationship with, as well as her colorectal surgeon, who did her original colorectal surgery. So we all put our heads together and we said, all right, let's take a conservative approach here, but try to help her. So in stage 1, we did a selective and subselective angiography of 5 superior rectal artery branches and embolized them. No periprocedural complications. In general, I give patients 1 dose of a periprocedural antibiotic on the day of the procedure, but we don't give them antibiotics going afterwards. But in her, because of her pretty severe immunosuppression, I worked with the transplant infectious disease doctors, and we gave her 5 days of antibiotics. 4 weeks after the procedure, absolutely no change in the frequency and severity of bleeding, and she kept having to get weekly transfusions to keep her hemoglobin at 8. So we said, okay, let's bring you back for stage 2. So brought her back, and she had collateralized, recanalized, and so we reselected these branches and treated these 4 branches again. Again, no complications, same antibiotics. 1 week post-procedure, she had no bleeding, no pain, and so we thought we were heading in the right direction. 4 weeks after the procedure, she was back in the ER with a hemoglobin of 4.7. Talked to her primary care and colorectal surgeon. They said we still really want to avoid surgery if at all possible. So I said, well, we can now start to look at the internal iliac branches. And so in this situation, I repeated and looked at the superior rectals again. She had yet another branch now that was flowing down, so we coiled that. This is most coils I've probably done in any patient. Then we started looking at the pelvis, and she had this innumerous rich collateral network of middle and inferior rectal artery branches, and it was the more you looked, the more you found. And so we tried to treat the things that were the most proximal or closest to the corpus cavernosum recti from the left middle rectal artery, but certainly there was still this rich network of inferior rectal arteries that we were not going to treat those, and I told her we would not treat those. And similarly, on the right side, we found middle rectal artery branches. Some were extensive, but she still had extensive collateralization from inferior rectal arteries. So after this procedure, absolutely no change in the frequency and severity of her bleeding. I did not recommend further embolization, as there were really only inferior rectal artery branches left, and I didn't want to cause this patient to have ischemia. She said she would rather be dead than ever have an ostomy again. So discussed with myself, her primary care doctor, her colorectal surgeon, the patient, and the surgeon said, well, given that all of these things have failed, we'll take the risk of a hemorrhoidectomy. And so she underwent that. She had severe pain for weeks after the hemorrhoidectomy, but I just looked the other day, and her hemoglobin that could never be above 8 without transfusion dependence is now 12, and she's non-transfusion dependent. So in the setting of these long-standing grade, really high-grade 3 and 4 internal hemorrhoids, the corpus cavernosum recti may have a really extensive, rich anastomotic supply, and embolization just may not be sufficient. As we've looked at the literature, up to 20% of patients don't have improvement. We don't necessarily know why. But key things are total devascularization is not safe, and sometimes all we can do is try, but even that might not be enough. Last thing I want to mention is cases I've just flat out said no to, because sometimes that's hard. We want to be helpful. But a recent case was somebody who had cirrhosis with chronic occlusion of the portal vein and SMV with bleeding both rectal varices and grade 2-3 internal hemorrhoids. They had undergone 2 hemorrhoid artery embolizations at an outside hospital, and they had absolutely no improvement. And I think that's really key, especially if you inherit a patient who's undergone one of these procedures before. Ask them how they did. So I sat down with the patient, and I said, since you had absolutely no improvement after these prior procedures, and they did a relatively good, they did a reasonable job doing the superiors and the middles, I said, this is not something I want to undertake. Another patient who had chronic mesenteric ischemia, bleeding internal hemorrhoids, but they had really severe vascular disease. So celiac artery occlusion, near occlusion of the SMA. The IMA was their best artery, and it was really supplying quite a bit of the celiac and SMA distribution. And they also had pretty good stenosis of the IMA. I said, this is not something I want to undertake. And then I'll occasionally get, and this is where we get a lot of emails from patients who see the study that we're doing, and they have hemorrhoids, but a lot of them really have low grade or grade 1 hemorrhoids without bleeding. And other symptoms. So that's something we'll say no to. So last slide, keys I think that were helpful for us in starting our practice. I think collaborating with the primary care physicians, the colorectal team, and GI really has been helpful, particularly colorectal. And I think being a clinical interventional radiologist, not just a proceduralist, having a clinic, seeing these patients, seeing them in follow-up. Patient selection, as Dr. Vidal mentioned, is absolutely critical. And we start conservative. Our goal is really to treat the dominant supply to the corpus cavernosum recti in the first stage. We can always come back. And learning when to say no is something that we're still learning, but it's important. And patient education and expectation setting is key. Again, it's important to inform them it's not necessarily curative. 80% of patients will have a significant reduction in the frequency and severity of their bleeding, but that means 20% won't, and we don't necessarily know why. Doing good selective angiography and embolization with large particles and dense coils, we found to be key. And having really a toolbox of base catheters, microcatheters, and wires, for most of the cases, you'll be able to get away with a few straightforward things, but in a few cases, we've needed to pull out some other tools. And I think having a low threshold to repeat an angiogram is good, but know when to stop. We don't want ischemic complications. And for me, as we started to get busier, I brought one of my colleagues on to do these too, because it's a lot more fun to work, with somebody who's also vested in this as well. It's really more fun as a team. So thank you for your time, and Dr. Vidal and I will be happy to take questions.
Excellent.
Yeah, so the question was if they have IMA occlusion or stenosis, but if they have dominant supply to the by middle rectal arteries. Yeah, that's absolutely something we consider. The other caveat in that patient was they had like iliac stents, and so their internal iliac arteries were covered. So in that situation, we really had no good option. It was a pretty significant vascular path, but I've not encountered that scenario. But I think, yeah, absolutely. If they had an IMA occlusion but access to their middle rectal arteries, yes.
Right. So I guess there would be there are some of my colleagues actually, they look at the CTA, and if the IMA is occlusion, they basically say that we're not going to do it. Versus you can say that we do an angiogram and see what is the status of the middle rectal arteries and then decide. So that's going to be basically you're putting the patient on the procedure on the table, knowing that IMA would be occluded, but there is a chance that you might be able to do the middle. So that would be, I don't know, how would you decide
Yeah,
on that point?
I think if we had a CT that showed us that, there was either going to be high-grade stenosis or occlusion of the IMA, but invariably then there's going to be something coming from, one or both sides of the pelvis. And in that situation, it's probably going to be hypertrophied. I've looked at the literature. It's a lot of coming from the colorectal literature. And if you look at where, in a lot of his cadaver dissections, where does the middle rectal artery come from? It's typically, most commonly pudendal, internal pudendal, or the gluteopudendal trunk, or occasionally the internal pudendal, rarely obturator. But yeah, so then I'll very closely scrutinize. I'll go down to the rectum, just like if you do PAE, you find the prostatic artery, and as it comes back, same thing. You find anything that's going down to the rectum and then trace it back to the wherever its parent artery is. I will say if you can get CTAs that are at least 0.6 millimeters, that will be helpful, particularly for small stuff in the pelvis.
Excluding patients solely based on grade, that's my question. Would you exclude a grade 1 with significant bleeding?
Yeah, at this point, I have not encountered a patient who has significant bleeding in the setting of grade 1 hemorrhoids. I don't know.
I haven't understood the question.
Would you do embo in somebody with grade 1 hemorrhoids with bleeding?
Yeah, if the patients had the really symptoms which give a bad life to him, you can do embolizations. But that means it's always a discussions, of course.
Yeah, I haven't come across that scenario, but I think if their bleeding was severe enough, then we'd just look.
Yeah, usually the surgeons never caught a patient which has bleeding, which is a really symptoms 1. They said it is 2 because there's always some congestive hemorrhoids. So it's really rare that it's 1.
Just go down the line, I guess, here. Before you put in coils, do you have an embolization endpoint, or do you just inject the 3/4 of a cc and then you go to your microcoils after that?
Sorry. It's hard to hear.
We listen very badly the noise.
Yeah, do you have an embolization endpoint with the particles, or do you just inject your 0.3, 0.4 cc's and then you put in the coils after that?
Really good question. So very similar to what Dr. Vidal described, where you just do a little bit, and so I'll load, I'll know what the dead space is of my microcatheter, and then I might put in, 0.3 of a cc, 0.2 of a cc, push with some saline, and then we'll check. And I'm not looking to get a standing column of contrast in the superior rectal artery branch. I'm just looking to see that blush of the corpus cavernosum recti go away. I don't know what you're with particles. Yeah. But yeah, when I've looked back at, I've even used as small as like a 1/10 of a cc, 0.2 of a cc. It's pretty rare to be using a large volume. Now, with that said, anytime somebody tells you this is how much I used, ask them what their starting volume. And so I always dilute these to 20 mLs. So that's where we're starting at.
Thank you. Yeah.
So you're talking about predominantly a venous disease. So why approach it from the arterial side?
Yeah.
For varicose veins in the legs, you're not embolizing the arteries.
But
so why are you approaching?
Hemorrhoidal disease is not a venous disease. It's clearly an arterial disease, and that's why the technical, the name of the surgery is hemorrhoidectomy with arterial ligations. It's clearly an AVM, like an AVM-like, the corpus cavernosum recti. So it's different of varicose vein that you can see with portal hypertension.
Yeah. So with some of these patients, and you get them describing their symptoms, they'll talk about, not a drip of blood, but blood shooting out. And so the arteriovenous connections, which are, present, pathologically, that's what they see when they look under the microscope. So there's an arterial inflow, the collection, and then a venous outflow. So it's not just a venous disease. I think for me, that was my understanding. It was a venous disease, and as I got to learn more, it's not. There's the paper from 1976. It's on the nature of hemorrhoids, and they do an absolutely beautiful job of showing these arteriovenous connections. But at least for me, that was something I never learned in my formal medical training.
That was the questions I asked to the surgeons when I saw the Doppler artery ligations. I said, what are you doing Doppler artery ligations because it's a venous disease? And he answered me, it's not a venous disease. But I was not aware. So
it is important, though, if these patients have any history of portal hypertension. That's something I'm always looking for. So we have treated maybe half a dozen patients now, and they love to send these patients. They're always thrombocytopenic, comorbid, and they always have some degree of rectal varices. I think it can help, but I do not think it's as efficacious as I tell them. What we know from the literature is not patients like you. It's up to 80% effective. It's probably less effective, but in a lot of those patients, they don't have options. The surgeons don't ever want to touch them. So we're willing to try, but I don't think it's as effective.
But anyway, you decrease the inflow. So.
Yep.
In patients with portal hypertension that get a TIPS, does that improve their hemorrhoid symptoms?
Sorry, it's really hard to hear. There's like something back here.
In a patient with portal hypertension that happens to get a TIPS, but also happens to have hemorrhoidal bleeding, do you notice the bleeding improve after the TIPS?
I have not encountered that scenario. Usually these patients who at least the ones that I've seen so two of them have had chronic portal mesenteric venous occlusion, and they've already gone on the route of, can they get recanalized? Can they have this? So at least in those two, they were not actually a TIPS candidate, and I have not had one come to me in the other four none of them have had a TIPS or gotten a TIPS.
Because for the people with portal hypertension, I'll do a transplantic venous sclerotherapy, and for those patients, that works really well. So that's why I was asking about, why not approach it from the venous side?
Yeah, so they have to have actual rectal varices. So the hemorrhoids are not rectal varices. So it is a totally different pathophysiologic process. Now I think they interact in that elevated back pressure with increased arterial inflow is going to make them more likely to bleed because of the elevated pressures. But this is not treating rectal varices, and that's something we always make absolutely certain of, that they don't have them or that's the cause of their bleeding.
I was curious if any research has been done to show what the particles do to the cushions pathologically after embolization.
I didn't pick the question.
Sorry, was it about the size of particles?
Well, I'm more concerned that the particles could cause some sclerosis, maybe prolapse later or something like that. I know there's been a debate going back and forth using coils alone or coils with particles, so I guess I'm trying to get your take on that.
Yeah, do the coils cause scarring in the rectum? Is that it?
Do the particles cause sclerosis of the cushions?
Well,
what do the
fortunately, none of the patients I've treated have had to go on for like a proctectomy, because we've not seen the ischemic complications. But we have them get follow-up anoscopy between 3 and 6 months, and there's usually a reduction in the size of the corpus, but we don't see frank scarring down of the tissues. It doesn't become just scar tissue.
Has pathologic evaluation been done of the cushions after embolization?
Yeah, I think the size of the particles we're using are blocking the inflow, but they're by no means ending up in the hemorrhoidal tissue themselves. I mean, I'm using 800 micron particles. They're not getting that deep into the tissue.
Thank you.
How many branches you go after in the first session, and when do you stop coiling?
So, I think
how many branches?
Yes.
Yeah.
So it's not a fixed number. It's what branches are hypertrophied and supplying the corpus cavernosum recti. So it really ends up being what you see on angiography. So if there are 3 branches supplying, we treat those three branches, and try to start as distally as possible. My goal is to start coiling at or just above the pubic bone. Sometimes you can't get that far, but we're certainly not doing proximal coiling, you know, in the very proximal left and right superior rectal arteries.
That's it. And usually it's between 3 and 5.
Yep. Thank you. I think the most I've done from the superior rectal artery it's mostly between 3 and 5, but I've had one that was 6, but that was quite the exception.
Yes. Okay.
I just wanted to confirm what I heard from Dr. Vidal about the technique. So my understanding is if you see the middle rectal artery, you always treat it. Is that correct? So when you do angiogram and you're done with the superior rectal arteries and you still see middle rectal artery, would you always treat it in the same session?
Yeah, if the size of the middle rectal artery is as big as the superior rectal arteries, I mean, if it's significant, I treat it in the same session.
How would you define significance?
How do you?
Sorry, how do you define the significance?
The size. If the size of the middle rectal artery is as big as the superior. If it's smaller, just wait and see 3 months. And if the results are good, it's okay. If the results are not good, you can go back. But if the middle rectal artery is as big as the superior rectal artery, I call it significant and I do it.
Thank you.
No? Okay. Yeah. Thank you, Dr. Thompson and Dr. Vidal. This was a great presentation.
Thank you all.
Any other comments? No?
Thank you all.
Thank you so much.
Thank you all. Bye.
Thank you.
Yeah, very nice session.